Hello, I'm Gail Shermack. I'm going to speak with you today about central auditory processing disorder, making informed, evidence-based clinical decisions. My financial disclosures consist of the following. I'm a professor and chair, speech and hearing sciences, the Elson S. Floyd College of Medicine, Washington State University Health Sciences, Spokane, Washington. I receive royalties from Plural Publishing. Financial compensation from ASHA for this presentation and past online presentations. I have no non-financial disclosures. The recommended practices for diagnosis and intervention for central auditory processing disorder are dynamic, undergoing review and refinement as new research emerges. These practices have been developed by consensus groups with careful consideration of the merits of various positions surrounding points of disagreement. Nonetheless, a number of controversial assertions and practices continue to appear in the literature. In this course, I would like to present my perspective on a number of these issues, highlighting the current state of the evidence supporting my viewpoint. I would also like to provide information that will assist clinicians in making informed, evidence-based clinical decisions. The gap between research and clinical practice continues to shrink as the need for evidence to substantiate clinical decisions becomes more necessary. Well spoken by our prior president, Gail Richard. In fact, this statement underlies an article that we published last spring in the Hearing Review, in which we argued science to support clinical practice positions. I'm going to cover these 6 topics in this session today: definition, nature, and causes of CAPD, ICD-10 and the global gold standard, differential diagnosis, minimizing confounds, efficient test batteries for diagnosis of CAPD, efficacy of auditory interventions, and future research needs. Central auditory processing disorder is a disorder of the central auditory nervous system. Deficits in the perceptual processing of auditory stimuli in the central nervous system and in the underlying neurobiological activity that gives rise to the electrophysiological auditory potentials. The predominant deficits characterizing CAPD manifest in the auditory modality. Central auditory processing disorder affects perceptual and neural processes underlying sound localization and lateralization, auditory discrimination, auditory pattern recognition, temporal processing, auditory performance with competed or degraded acoustic signals, and others, for example, spatial processing or spatial release from masking. There are many functional deficits or behavioral manifestations associated with CAPD, perhaps the most characteristic being the difficulty understanding spoken language in competing message or noise backgrounds, in reverberant acoustic environments, or when rapidly presented. As you can see in the last slide and in this slide, there are many behaviors that are seen in individuals with CAPD. These difficulties are not definitively diagnostic of CAPD. As you can tell from the behaviors listed, these deficits, difficulties can be seen in individuals with a variety of problems, from central hearing loss to peripheral hearing loss, language processing issues, attention deficit issues, and so on. CAPD affects individuals across the lifespan. It's due to benign neuromorphological anomalies, neuromaturational delays, or acquired neurological brain damage suffered from head injuries, strokes, tumors, and the like. CAPD is also seen within the context of cognitive syndromes, certain types of dementia, psychiatric disorders, or age-related changes to the central nervous system. And it is diagnosed on the basis of a battery of tests with documented sensitivity in patients with confirmed neurological lesions of the central auditory nervous system. It is not diagnosed on the basis of parental or other informant's report or questionnaires. This slide displays some of the common neuroanatomical and neurophysiological sources of abnormal processing or delayed immature processing. Interhemispheric transfer deficits, which in children likely due to developmental delay in myelination, lack of appropriate hemispheric lateralization, atypical hemispheric asymmetries, imprecise synchrony of neural firing, decreased central inhibition, probably others, and in older adults, loss of myelin integrity, neural slowing, decreased brain connectivity, and so on. I'd like to elaborate a bit on the causes of CAPD in children. Primary causes, neurodevelopmental and acquired. Under neurodevelopmental, we find maturational lag, likely due to delayed myelination, and possibly auditory deprivation, seen in about 20 to 30% of the cases. Neuromorphological errors, seen in 60 to 70%. These are underlying benign, diffuse neuroanatomic or neuromorphological abnormalities such as polymicrogyria, in which we have misshaped smaller cells, or heterotopias, where we have cells that are normal, but they are in the wrong places in the brain. And then we have a very small fraction of children with CAPD who have acquired CAPD due to some type of neurological disorder. That's 5 to 10% of the population. Although we tend to think about neurological disorders as a cause of CAPD in adults, we also see it, although in a small percentage, 5 to 10%, in children. And in a 2011 article, Frank Music and I described some of the acquired pathologies seen in the central nervous systems of children, as displayed on this slide. What about the causes of CAPD in adults? Of course, the adult could have a neurodevelopmental disorder since childhood, which was either diagnosed or perhaps not, or they could be experiencing an acquired disorder due to a neurological lesion or compromise of the central auditory nervous system, including neoplasms, neurodegenerative processes like multiple sclerosis or Alzheimer's, head trauma, impaired cerebral circulation as a result of a stroke. Let's not forget changes in the central auditory nervous system, a type of presbycusis due to aging, noise exposure, and neurotoxic chemicals or heavy metal exposure. In fact, from the 7th decade of life and beyond, central auditory function, as measured by behavioral tests, declines more than pure tone sensitivity or outer hair cell function. In fact, some have suggested that CAPD may be a precursor of cognitive impairment. I'd like to spend a few minutes talking about the ICD-10 and the gold standard. Some have challenged the veracity of CAPD as a diagnostic entity, claiming that it is ill-defined and poorly understood. While there is some disagreement between the professional associations in the U.S. and European associations, the two major sets of guidelines published by professional associations in the U.S., ASHA and AAA, present consistent evidence-based positions and recommendations. Moreover, CAPD is listed in the ICD-10 under ear diseases, code H93.25, for both acquired and congenital CAPD, which confirms the physiological nature of this disorder and supports the medical necessity for care. Some have argued that there is no gold standard CAPD diagnostic test battery. Consistent with medical terminology, which defines gold standard as a method or procedure that is widely recognized as the best available, it's my position that while there might not be a universally accepted gold standard, We have a considerable body of research demonstrating the efficiency of individual central auditory tests and central auditory test batteries based on performance of individuals with confirmed central auditory nervous system lesions, including such lesions in children. Consider, for example, Music et al. And Wang et al., who reported similar performance on multiple central auditory tests in a group of patients with confirmed neurological lesions of the CANs and a group of children with CAPD diagnosed on the basis of an efficient behavioral test battery recommended by AAA and ASHA, respectively. Boscariol and colleagues have demonstrated that children with known CANS lesions present central auditory behavioral test performance patterns and brain imaging similar to those seen in adults with known central auditory nervous system lesions and similar to those seen in children with developmental CAPD. That is, a child who shows no identifiable lesion of the CANS and no apparent prenatal or perinatal disease, injury, or exposure-related explanation for the CAPD as well. Let's spend a few minutes talking about differential diagnosis, the importance of minimizing confounds. The potential for language and cognitive confounds are seen with any task that requires cooperation and behavioral response on the part of the individual being tested. All auditory tasks, from pure tone detection to spoken language processing, are influenced by higher-order, non-modality specific factors such as attention, memory, motivation, and decision processes. Why is it important to minimize confounds? We need to reduce the risk of false positive diagnosis. Pediatric CAPD is often comorbid with other disorders that can influence central auditory processing test results. Remember, the audiologist's role is not just to determine which central auditory processing tests are failed and how many, but whether the negative influence of comorbidities can be ruled out. This figure, taken from Sharma et al. In 2009, demonstrates the likelihood that a child with central auditory processing disorder is going to present with other disorders. You can see that 47% of their sample experienced auditory processing disorder and comorbid reading disorder and language impairment. There are means to minimize confounds. We can design tasks, as we have, that inherently require minimal cognitive and/or language skills. We can select tests commensurate with the patient's abilities. So, for example, if a patient has memory issues, select tests with low memory load, for example, gap detection or dichotic digits. If an individual has a peripheral hearing loss, select tests that are less influenced by hearing level, such as the frequency and duration patterns tests and the dichotic digits tests. Use nonverbal or simple speech stimuli. For example, again, frequency or duration patterns, gap detection, and dichotic digits. In addition to selecting particular tests, we can also minimize confounds using intra-test measures to control in part for non-auditory factors, asking the question, are performance deficits on our central auditory processing tests due to acoustic manipulations or lack of familiarity with the language and/or significantly reduced memory or attention? So we can compare between ears, and I will show you an example of that in the next slide. We can monitor or measure performance intensity functions, what happens to performance as we increase intensity. We can compare the humming versus the labeling response in frequency pattern or duration pattern tests. We can check performance in non-manipulated conditions, looking at monaural versus dichotic performance or non-filtered versus filtered speech performance. And we can examine tasks that differ in the demands placed on auditory processing, but that differ minimally in the demands placed on cognitive abilities, as is done in the listening and spatialized noise test. As you can see in this slide, adapted from a figure in Bellis et al. 2011, the performance across 3 different groups on dichotic digits shows a very different interoral outcome. For children diagnosed with central auditory processing disorder, there is a clear right ear advantage or left ear deficit. For the normal children, there is little, if any, advantage. Both ears perform essentially the same. And for the children diagnosed with attention deficit hyperactivity disorder, there is some slight right ear advantage, but it's not nearly as large as that seen in the children with central auditory processing disorder. Another important way that we can minimize, if not isolate, confounds is through multidisciplinary evaluations. Each team member contributes to the differential diagnosis of the patient's disorders, identifying disorders in a variety of areas that might be contributing to the profile and might be potentially problematic for our test battery, as it might be for other members of the disciplinary team. And of course, when cognitive or language processing deficits are suspected or confirmed, and the audiologist is not at all convinced that she or he has isolated those other deficits, the audiologist should then consider the use of auditory evoked potentials rather than relying on behavioral auditory tests, which nonetheless, those AEPs or auditory evoked potentials would still be interpreted within the context of a multidisciplinary evaluation. Next, I would like to talk about the efficient test batteries for diagnosis of CAPD. Based upon a lot of published research, we have concluded, based on sensitivity and specificity data, that these 4 tests, gaps in noise, either frequency pattern or duration pattern test, dichotic digits, and masking level difference, are the 4 most efficient tests for diagnosis of CAPD in adults. In addition, of course, case history, very necessary component of the test battery, and any pertinent medical or neurological reports. Here you see a table reproduced from a chapter we wrote in 2015. The reference is in your reference list, in which we identified the different tests that would contribute information to differential diagnosis, with particular reference to a level of the central auditory nervous system or the peripheral auditory nervous system. We included a similar table in a recent article in the ASHA Leader. This time, however, we added some of the evoked potential information in terms of their contributions to differential information relative to various levels across the auditory system. Again, a reference in your list. What you see here above the blue line are some of the data we have pulled from various publications demonstrating the sensitivity and specificity to various levels of lesion, cortical and otherwise. And then you see below that some of the other measures like low-pass filtered speech, which seems to have less sensitivity, even to brainstem and temporal lobe lesions. Many ask the question, how many tests do I need to administer to diagnose CAPD? We examined that in a couple of publications, and as you can see in this adapted figure, 2 tests probably gives us the best compromise between sensitivity and specificity, at least for the tests we were using in these 2 studies. If you add more tests, you certainly improve your specificity, but you lose your sensitivity, and therefore you compromise overall efficiency. And if you use 1 test that is particularly sensitive to CAPD, you will get 100% sensitivity, but you're going to have a lot of over referrals. You're not going to have very good specificity. You're going to overdiagnose individuals who don't have the disorder. So the best compromise seems to be 2 tests. And in adults, those 2 tests seem to be dichotic digits and frequency patterns. So showing you again the slide that I showed just a few moments back, while we have 4 tests that have very good efficiency with adults for the diagnosis of CAPD, we found in our work that the dichotic digits and the patterns test were the most sensitive. Does that mean that I should say the most sensitive and specific, forming the best compromise for efficiency? Does that mean you should never bother with the gaps in noise or the masking level difference? I would suggest that if you are able to administer more than 2 tests, more than the patterns and the digits tests, by all means do, because you will collect more information, in particular using masking level differences and even the gaps in noise. You're going to obtain more information related to the brainstem, because if you go back to the 2 tables that I referenced earlier, you'll find that dichotic digits gives you much more information about the cortex and the corpus callosum, and the duration patterns, similarly, much more information about the cortex and the corpus callosum. So if you want to look a little lower down in the central auditory nervous system, masking level differences and gaps in noise will give you more information at those lower levels. Moreover, if you have more information, meaning you've tested more of the auditory processes underlying central auditory processing, you have more information that will help you moving forward with a treatment plan. And as noted before, there are times when auditory evoked potentials become absolutely essential. They're always of interest, but they're not always essential to the diagnosis, the clinical diagnosis. But here, I'm sharing with you a slide that Frank Music compiled representing sensitivity and specificity data for MLR and ABR. And you see again that these are very impressive data. Sensitivity, specificity, and therefore overall efficiency. What about the efficient behavioral test battery for children? You'll see some definite overlap between that for adults and that for children. In fact, the slide is identical, the recommendation is identical, except that we have substituted low redundancy speech for masking level difference. And I'm going to talk more about low redundancy speech as we move through the next few slides. But keep in mind that here we have 4 very efficient tests, some more efficient than others, and again, I'll come back to that. But also note that the case history is an essential component of the behavioral test battery with children. Here's a figure from our 2015 study in which we compared the failure rates across a number of tests in our battery. And you'll find that the children with CAPD failed in large numbers all of the tests in the battery. You'll also notice, however, that the children who were normally processing, the NPs, actually failed the low-pass filtered speech test with a fairly high rate of failure. In fact, we can't be sure that the children's difficulties on low-pass filtered speech was reflecting an auditory processing issue. It may have also reflected their knowledge of the language and specifically comprehension of single words when sentence context is absent. The 2-test combination that showed the next highest failure rates among children with CAPD and did not include low-pass filtered speech was competing speech and frequency patterns. However, if one wishes to include a dichotic measure that has a lower linguistic load than competing speech and potentially might have a bit less sensitivity but much higher specificity, then we recommend substituting dichotic digits, notwithstanding the slightly lower failure rate of the dichotic digit frequency pattern battery relative to the competing speech frequency pattern battery. I'd also like to share with you some data, again compiled by Frank Music, showing some of the specificity some of the sensitivity data for children with various types of disorders and typically developing children. Again, pointing out that electrophysiological measures are useful in the evaluation of children as well as adults. So we come back to the slide I showed you a few slides back, the efficient behavioral test battery in children, this time highlighting the patterns tests and the dichotic digits as our go-to test battery with children. We feel provides the best compromise between sensitivity and specificity and therefore most efficient. Again, as I said with adults, this is not to suggest that you should never use any other tests in the battery. The gaps in noise and low redundancy speech may be quite useful. Gaps in noise can provide some information not only about detection, but also provide information about brainstem function. And low redundancy speech, while it is linguistically loaded, does provide a more functional measure of auditory closure, for example. And so that could be very directly translatable. Results on that test could be very directly translatable to an intervention goal. Now that we've covered diagnosis, let's talk a little bit about the efficacy of auditory interventions. Some have criticized auditory training as ineffective because it does not improve language or reading skills. However, reading and language processing are influenced by many variables, some of which are far removed from the auditory domain. The purpose of auditory training is to improve auditory processes, not to improve language or reading skills. Moreover, true auditory interventions utilize auditory training exercises, behavioral tasks that are auditory-based and aim to strengthen the basic sensory processing of auditory stimuli at the level of the central auditory nervous system. Language, metacognitive, and cognitive interventions are not auditory interventions. A number of computer-based auditory training programs that have been suggested for treatment of CAPD are language-loaded, for example, aerobics, fast forward, and they are not truly auditory interventions. Auditory training as a bottom-up strategy aims to improve sensory processing of individuals with auditory skills deficits, with the expectation that such improvement is likely to benefit real-life listening situations. Improvement in areas not directly related to the targeted auditory deficit, for example, reading and spelling, may occur, but is not the primary goal of auditory training. Several recent studies have provided behavioral and electrophysiological evidence that auditory training improves auditory processing skills of children with CAPD or auditory-based learning problems. Here you see a table taken from a 2015 publication in which we summarize the evidence available at that time supporting the efficacy of auditory training. I'm going to focus on two studies, one which was conducted after this publication, a 2016 study, as well as spend a moment on the Cameron and Dillon 2011 study that's shown in this slide. Both of these studies present level 2 evidence. So Liu et al. In 2016 conducted a non-randomized experimental but controlled study in which they trained children diagnosed with CAPD as per ASHA criteria in several speech and noise tasks and in dichotic listening tasks. They reported better speech recognition and noise on all conditions of the Listen-S test, as well as in functional listening, measured by the CHAPS questionnaire, and in the use of language as measured by the SELF. Similar improvements were not seen in children with CAPD who did not undergo training. The Listen and Learn, an auditory training program specifically developed to improve binaural spatial skills and speech recognition and noise, was shown to be effective in improving binaural processing as measured by the Listen-S test. Enhancements to self-reported ratings on listening skills were also reported. And the children with spatial processing disorder who did not undergo training or underwent another training program, in this case, aerobics, did not demonstrate the same benefits, highlighting the importance of auditory interventions that are deficit-specific. Most of the published auditory training protocols lead to improved auditory function following a schedule of 15 to 45 minutes of training, 2 to 7 times a week for a period of 2 to 3 months. Post-training benefits have been demonstrated to persist after 3 to 36 months of the end of the training program. However, maintenance of these benefits over longer time periods has not been investigated. The evidence reviewed here demonstrates that auditory training is an effective treatment for central auditory processing deficits. Clinicians and researchers might disagree as to the quantity of evidence needed to support the acceptance of scientific results. However, none should confuse any perceived concern about quantity of evidence with the demonstrated positive outcomes of that evidence. I would like to mention research needs in 4 areas. One reflected in this slide, which I will just speak about in a minute, well-defined research participants, and 3 other areas, differential diagnosis, electrophysiological measures, and tests to diagnose children at younger ages. Participants diagnosed with CAPD, not simply suspected of based on a parental report or a questionnaire, are the kinds of participants we need in our studies. A recent European consensus on APD reached by professionals in 17 European countries noted that the 2 primary reasons why debate around CAPD lingers are 1, failure by critics to employ the currently available auditory processing test batteries with demonstrated efficiency, which then leads them to draw conclusions regarding CAPD based on characteristics of individuals who are not diagnosed with CAPD and are so-called suspected of presenting CAPD. We've already discussed comorbidities and confounds. I'd like to draw your attention to a new acronym on the block, HHL, which stands for hidden hearing loss. Hidden hearing loss refers to individuals who have difficulty understanding speech and noise despite normal audiograms. It might sound familiar to you because that is an earmark of central auditory processing disorder as well. However, the term hidden hearing loss really refers to a peripheral neural issue at the synapse between the inner hair cells and the afferent fibers. And I have to say that at this point in time, there is limited evidence that hidden hearing loss underlies this perceptual deficit of difficulty understanding speech and noise despite normal audiograms in individuals, humans. There is a bit of research done on animals, but we do not yet know whether hidden hearing loss or this deficit that is seen in the afferent fiber inner hair cell ribbon synapse communication really underlies any of these individuals we are seeing with the difficulty understanding speech despite a normal audiogram. In fact, the research suggests so far that you'd have to lose 80 to 90% of the synapses with the inner hair cells before behavioral shifts would begin to show. I'd also like to draw your attention to the future in terms of the use of electrophysiological paradigms, hybrid approaches, perhaps where psychophysical tests were injected into electrophysiological paradigms. For example, recording auditory evoked potentials in response to stimuli used in behavioral tests, or while an individual concurrently performs a behavioral central auditory test. These types of hybrid approaches would provide more objective information and might in fact be more sensitive than comparable behavioral indices. And they would reflect the integrity of both neural substrate underlying behavioral tasks and the pathways responsible for generating the auditory evoked potentials. And such hybrid approaches might provide objective measures of which patients might benefit from particular training and of treatment efficiency and efficacy. I would also add brain imaging work, which although very expensive at this point and not used clinically for the diagnosis of CAPD, could at some point be a useful tool to identify some of the underlying issues that we see manifested in our behavioral tasks. And the fourth area for future research focus is thrown here as a challenge. Tests and procedures are needed to enable early diagnosis of CAPD in children 7 years and younger to maximize the efficacy of intervention. To do so, however, is going to require research to find measures of sufficient challenge to the central auditory nervous system that can still be completed by young children without such variability that makes it impossible to establish reasonable cutoff norms. In the meantime, we and others have recommended a number of informal interventions for children who are at risk but have not yet been diagnosed with CAPD. My presentation is part of the upcoming ASHA Audiology Online Conference on Central Auditory Processing Disorder. This conference examines the complexities of CAPD, including how to select evidence-based measures for evaluation and diagnosis, and how to interpret results accurately. We'll also explore useful and specific recommendations for intervention to improve auditory processing and achieve functional outcomes. You'll learn from both audiology and speech-language pathology perspectives, and also get up to speed on the measures used by other professionals to examine potential comorbid deficits in psychosocial, educational, and neurocognitive areas of individuals with CAPD. You can learn more at the URL on this slide. I would like to thank everyone for your attention and to let you know that I will take your comments and I will answer your questions during the live text chat session. Thank you again for your attention and your participation.